Let's keep them connecting. We are going to start with a quick roll call of the districts to see what districts are connected and which are not. So please make sure not only your districts, but your facilities are also connected. Donc, on va commencer avec la tendance. On va prendre la tendance. Donc, assurez-vous que votre district est connecté et le site est aussi connecté là-bas. On va commencer dans 1 minute. In 1 minute time, we are starting. And we are just 17, and we have more than 50 people registered. Okay, once again, good afternoon to everyone. Good afternoon. Like I said, I'm seated with a team. I am presently in the Mwa Health District, and so I'm sitting with the Chief of Bureau Health for Mwa Health District in the person of Madam Sama Dorothy. There are other staff from the Mwa Health District, as a district hospital, who are connected. We also have our other districts connected. So very rapidly, I'm just going to go through the districts. If I mention your districts, please, you just say present so that we can note attendance for the districts that are here. Because the activity for today largely concerns the districts. And so we really hope that a lot of our districts are connected. So if you are from the district and I call the districts, please do well to respond. Like I said, I'm seated with the Chief of Bureau Health for the Mwa Health District, and so Mwa is connected. Do we have ACO connected? Is ACO connected, please? Not yet. Do we have Baham connected? Baham. Leslie, I saw you earlier.
I'm connected to, we are trying to, we are in a meeting. There are many people and we are trying to connect. They are not able to connect. I'm trying to connect them.
Okay, so Baham is there and he's trying to get his team connected. Thank you. Do we have Bamenju? Is Bamenju connected, please? Okay. Do we have Banjo connected? Banjo. Bankomo. Bankomo. Okay. Mintum.
Présente.
Merci, Doc. Et Jum?
Oui, ici là.
Merci, monsieur Bissot. Donc, on a 4 sur 8. On a 4 sur 8 districts connectés déjà. Donc, je pense que les autres vont nous rejoindre. Est-ce que Ako est là? Is Ako connected now? No. Bamenju? No. Banjok? Bankomo?
Banjo says she's trying to connect.
Okay. Please, when she connects, let her just put in the chat. And then Bankomo. Bon. Once again, good afternoon to everyone. And we are just going to go right ahead with our PATA REAL. So I think PATA REAL is not a new concept, but this is the first PATA REAL we are having in the year 2026. And PATA REAL is an acronym that stands for we review cases, we engage with our peers, We have access to experts and we learn lessons. And through PATA REAL, we want that everybody within the districts we are supporting have the same level of information. And that's why we are able to bring your peers to present cases to you. We're able to bring access to experts to comment on the cases that we are presenting, just so that at the end of the day, the lessons that we pick from it, we can replicate. Slide, please. We are a very inclusive world, and so translation is available. All you need to do is go to the bottom of your screen and you will see this icon that looks like a globe where you see interpretation, and you can connect there. You would see that there's an English channel, there's a Portuguese channel, and there's a French channel. But for this session, we are having translation from English to French and French to English. And so if you need French translation, you are going to click the French channel. If you need English translation, you click on the English channel. Bon, juste pour dire qu'il y a le traduction qui est disponible. Angelita, can you go back to the previous slide, please? Donc, vous partez au-dessus de l'écran, vous pouvez trouver les icônes ci. Vous cliquez sur ça, vous pouvez trouver les différents langues que vous pouvez choisir. Donc, si nous tous on fait comme ça, on va avoir les traductions. Bon, pour aujourd'hui, for today, we have, please, when you come in, mute your mic. Thank you. For today, we are going to be talking to pediatric fetch. The fetch is a strategy that our country is carrying out, and it stands for Find Every Child. And for today, we have been able to bring on board presentations from 2 districts. We have the district of Mintom who will be presenting, and also the Mwahel district who will be presenting. What we want to learn from the district is what they have been able to do so far in terms of fresh activities and where there are gaps in case identification. And then we are going to have a presentation from an expert in the person of Dr. Yefo Alet. She is the Regional Technical Supervisor for Pediatrics Activities with the Cameroon Baptist Convention Health Board in their HIV-free project. So after we've had the 2 presentations, she is going to be speaking to us again, just so that we understand what FETCH fully stands for and how we can do to attain the targets for FETCH. We also want to call on people, because we are cognizant of the fact that in this meeting, we have people from sites that are not part of the breakthrough site, but these people from these other sites have been implementing fetch activities and so have a certain level of experience, which we are hoping they will be able to share with the teams from the breakthrough partnership sites. So I just want to crave your indulgence that please, during the discussions, feel free to share back best practices and strategies that you have used that has yielded fruits. So without much ado, I would like to welcome Dr. Abada from the Mintom Health District, who is going to be presenting to us the situation of Mintom. Dr. Abada, si vous m'attendez, you have the floor. Thank you.
Ok, bonsoir à tous et merci pour cette opportunité que vous nous donnez de présenter un peu les activités FASH du district de santé de Mintom. Je suis le chef de district de santé. Diapo. En termes de contexte, il faut dire que slide. En termes de contexte, il faut dire que le district de santé de Mintom est un nouveau district. C'est le 13e district de la région du Sud qui a été créé en juin 2024. Nous avons une population estimée à 8305 avec les répartitions telles que nous les voyons. Les enfants 0 à 9 ans, nous sommes à 1881. Les enfants de 10 à 19 ans, nous sommes à 659 qui sont nos cibles pour l'activité FUSH. Il faut dire que pour ce qui est de la prise en charge des enfants vivant avec le VIH et des adolescents, nous avons implémenté ces activités depuis environ 5 ans, mais nous avons eu un saut de l'implémentation de ces activités en 2024 avec l'appui de nos partenaires qui sont le KIT Air et ECPAV. Diapo. Il faut dire que les défis pour ce qui est du dépistage des enfants de 0 à à 19 ans, c'est essentiellement l'accord parental qui est un frein à ce qu'on puisse dépister tous ces enfants-là. Et pour ce qui est des défis additionnels, nous avons celui de la rupture intermittente des écrans de dépistage du VIH. À l'ère où nous sommes à l'algorithme macro-test, il peut s'avérer que dans certaines périodes, il n'y ait pas tous les croix-tests pour pouvoir faire ce dépistage chez les enfants. Il y a aussi une insuffisance d'implémentation. Il y a aussi une insuffisance d'implémentation des stratégies avancées et adaptées à cette tranche d'âge et l'absence de laboratoires de dépistage de ces enfants exposés au niveau du district sont vraiment nos plus grands défis. Qu'est-ce qui peut expliquer qu'on manque les enfants? Nous avons essayé de faire une étude tout au long de l'année 2025 pour voir à quel niveau nous manquons souvent nos enfants. Il s'agit surtout du service de vaccination où nous sommes en nombre très réduit dans le district. Et ce qui fait que parfois, au service de vaccination, nous ne dépistons pas optimalement ces enfants-là. Le service de consultation externe et pédiatrique, où certains consultants se focalisent surtout sur des pathologies que ces enfants présentent et lors des stratégies avancées et des consultations prénatales et des autres services intégrés, parfois nous oublions de faire le dépistage à ces enfants. Et nous avons aussi un problème pour les aides qui ne sont pas soutenues dans ce cadre du FESH, qui font que nous manquons beaucoup nos enfants. Diapo. Pour ce qui est de la stratégie FIRST, qui est de trouver chaque enfant, surtout les enfants vivant avec le VIH, pour qu'ils puissent passer leur deuxième anniversaire, il faut dire que cette stratégie a été implémentée au sein du district dès février 2026 et nous avons eu à briefer, c'est-à-dire former tous les chefs d'aide à cette approche, c'est-à-dire rechercher tous les enfants qui sont nés de mères VIH positives ou bien qui ont eu une histoire d'orphelin ou bien de décès ou avec des pathologies répétitives. Il est question de tester tous ces enfants. Nous avons donc formé les différents chefs d'aide. Nous rappelons ici que dans notre district, nous avons 5 R et 7 formations sanitaires. Nous avons formé ces 5 formations, ces 5 R. Et cette activité se veut complémentaire à celle que nous avons commencé les années antérieures avec le pédiatrie search, mais elle se veut vraiment à l'approche district qui voudrait que chaque enfant ait la chance d'être atteint. Diapo. Comme nous le disons, slide. Comme nous le disons, nous sommes l'activité FERJ groupe 5 aire de santé et nous faisons une descente par mois. Au préalable, il faut faire une line listing de tous les potentiels enfants nés de mère VIH et de tous les enfants malnutris et des enfants qui ont des pathologies à répétition avec l'aide aussi des agents de santé. À la suite de cela, nous faisons donc une descente où nous testons tous ces enfants-là et nous remplissions les scans formes des cas contacts, des cas index. On fait la numérisation et on poursuit en termes de prise en charge au cas où le cas s'avère positif. Et le suivi psychosocial est complété par l'introduction progressive de ces enfants dans les groupes de soutien qui sont dans nos districts. Il faut dire que les premiers résultats des notes, slide, please slide,
Oui, le diapo est changé, donc.
slide. Les premiers résultats de cette activité, on a eu à faire une seule descente pour le moment en février qui allait de la période du 19 au 22 février 2026. Il était question de faire des dépistages et des prélèvements. En termes de cas index recensés, nous avons eu 8 femmes enceintes, femmes allaitantes, femmes tout court confondues, positives, avec 2 enfants à qui on a fait le prélèvement de PCR et 14 enfants à qui on a fait vraiment le dépistage. Et au bout de ces résultats, nous avons eu un enfant positif et les PCR sont en attente. Diapo. Diapo, please.
Oui, ça a changé.
Il faut dire que les approches de dépistage qui marchent le mieux dans notre district, c'est vraiment le dépistage par cas index suivi de dépistage familial. Le dépistage ciblé au point d'entrée n'a pas encore montré un rendement vraiment spectaculaire par rapport au dépistage des cas index et familiaux. Le dépistage communautaire est en plein démarrage d'implémentation dans le district, mais il n'est pas encore optimal pour des questions de confidentialité. Il faut dire que, Diapo, au niveau de la coordination, même au niveau du district, slide, nous faisons à ce que nous soyons plus au niveau de l'approche district. Avec l'approche district, nous voulons vraiment améliorer le dépistage et l'identification des enfants vivant avec le VIH. À travers quoi? À travers les réunions de coordination qui sont appuyées par nos différents partenaires. Nous avons des réunions de validation des données au niveau avec d'abord l'équipe cadre du district et ensuite avec les formations sanitaires. Qu'est-ce que nous faisons aussi? L'hôpital de district qui est habilité vraiment à faire tout cette prise en charge va appuyer les autres formations sanitaires qui ne sont pas encore soutenues. Et nous avons aussi l'opportunité des supervisions PTME et vraiment l'effectivité, l'implémentation de l'approche district. On voudrait que toutes les formations sanitaires puissent s'arrimer à tout ce qui est santé publique dans le district. Et nous avons le soutien aussi pour les activités communautaires avec l'ensemble de nos aides, avec notre partenaire Kit Air. Et pour cette année, nous comptons vraiment activer avec les Modern Mentors, qui est une opportunité pour la vaccination et les stratégies avancées. Et nous essayons de faire la disponibilisation des écrans de dépistage dans les formations sanitaires. Pour ce qui est des leçons apprises, nous pouvons dire que, Diapo, le suivi de proximité des personnes vivant avec le VIH peut améliorer le dépistage des enfants et que ces enfants-là, les enfants positifs ou les enfants exposés ne tombent pas du ciel. Ils découlent parfois d'un parent malade et d'une histoire familiale de VIH. Donc, qu'on n'aille pas chercher ailleurs, faire des dépistages vraiment communautaires. Il faudra qu'on fasse des dépistages ciblés comme les stratégies le veulent et que le dépistage de l'enfant est déterminant pour sa suivi parce qu'on sait que si l'enfant n'est pas dépisté à temps, il ne pourra pas atteindre ses 2 ans s'il est VIH positif. En termes d'action, dans les 30 jours diapo que nous voulons mener dans les 30 jours, c'est quoi? Nous voulons vraiment saisir l'opportunité des Modern Mentors pour renforcer le dépistage au cours des vaccinations et au cours des stratégies avancées, faire le suivi rapproché des cas index hebdomadaires et essayer d'appuyer, que le laboratoire appuie le dépistage dans les autres aires et renforcer le dépistage ciblé à toutes les portes d'entrée. Merci pour votre aimable attention. Je crois que voilà en gros les activités FUSH dans le district de santé de Milton. Merci.
Merci beaucoup, Dr. Abada. Merci pour the presentation. Once again, good afternoon, everyone. If you are just joining us, we are discussing FETCH, which is Find Every Child, a strategy that we are carrying out in Cameroon. And we want to really make sure that all the districts that are supported by the Pediatric Breakthrough Partnership are in sync and carrying out these activities. There is interpretation available for those that are just joining. So if you go to the bottom of your screen and you see the icon that looks like a globe, you can click on it and you have interpretation available. Like I said, PATA REAL, we have the opportunity to review like we've just did, but also to engage with experts. And so I would like to just call on 2 experts who are going to speak a bit to what Dr. Abada has presented. Maybe they have a comment or a question. They can do that. And for other participants, please, if you have something to say, you can raise your hand. You can also use the chat. Please use the chat to introduce yourself and also to put the comments that you have. So right away, I'm going to call on Dr. Asong. to give a few comments to the presentation, and after we'll have Dr. Alette. Thank you, and over, Dr. Asong.
Thank you very much, Dr. Vanessa, for giving me the opportunity. Thank you very much, Dr. Apada, for the wonderful presentation and also for the wonderful job you guys at the district have been doing, especially regards to fetch. I think if I want to summarize your presentation, there's a statement you made that HIV positive children do not fall from the sky. That is already a highlight, just to tell us that those children are present, and it's left for us to find strategies that we can use to get them. You mentioned a lot of strategies, specifically about index testing, about using mentors, which I believe these are strategies that have worked in other communities. I just want to say that when you are using these strategies, it is always important to contextualize the strategies. Communities are different. So if we generalize these strategies, we might have troubles or problems making sure that they achieve the goal that you want to achieve. All right. I also have some other suggestions, which of course you can always tell us if at all these strategies actually meet the context in which you people are working in. Index testing has always been a joker. It has always been the best strategy, but it always begin by finding these women who have given birth in the community. If you don't do proper line listing to locate these women, you might have problems identifying their children. There are many communities where we go into and you find out that, hey, this specific woman gave birth to 5 children, 4 are dead. It's common in our communities. That's just to tell us that these children were not really followed up, were not identified early enough. And because of that, the outcome that these children had at the end of the day was them dying. Most, of course, is due to HIV. Other strategies that have worked in other communities basically is all about integrating the HIV testing or case finding into the normal or routine activities of the routine immunization, routine malaria programs. So as using a district approach, you can engage your facilities to normalize the aspect of HIV. The problem we generally have is that people still stigmatize HIV a lot. So using a normalizing attitude towards HIV might go a long way to make the community engage in HIV testing, and it might also help you identify some of the children. Another way is through engagement. We know where these children are. Now, there is the forward process of identifying the mothers before getting the children, but there's also a reverse process of identifying the children and then linking up with the mother. Children are found in schools, in youth programs, which I believe if at all your district forms partnerships with maybe schools or specifically with teachers or youth clubs, they can try as much as possible to engage in sensitization talks, education talks, and this alone can push these children to come for testing. If you identify a positive child, you can trace that child to the mother, and also it's going to help you to identify the siblings. That's just a way of you also doing some form of reverse index testing. In our communities, we have OVC, we have orphans. So it's good that if we have a network of social workers, churches, community leaders who can identify, okay, these orphans, it can go a long way to help us use through these orphans to identify the mothers. There's a strategy that has worked in a specific community that I'm not going to mention. They call it a community door-to-door strategy. these communities actually map out, they have a map out of their community, so they know where each and every person is. So they do a systematic household sensitization and testing. Okay, this in a way will help you identify, especially in cases where the parents are late or the parents are not around and the children are living with their grandparents, which is common in our African society. So I just want to see there are a lot of other strategies that we can use. And I believe that if we integrate it based on the context of where we work, it is going to go a long way to help us identify these children. Thank you, and over.
Thank you very much, Dr. Asson, for that. I think some of it was actually reiterating what Dr. Abada said. I think the key points, like you said, is that children who are HIV positive do not fall from the sky. And so we need to do everything to find them, and we should contextualize our strategies. Thank you. Dr. Alette, if you have something to add, you have the floor. Thank you.
Thank you. Thank you very much, Dr. Vanessa. Thank you for organizing this PATA conference. Thank you, Dr. Bertrand, for your introduction. As you have spoken in English, I think I'll continue in French so that Doc will be able to hear very well. Doc, merci beaucoup pour ta présentation. C'est déjà très intéressant de voir ce que vous avez pu faire et d'avoir pu analyser la situation de votre district, de connaître les défis, de connaître les opportunités que vous pouvez avoir pour améliorer votre performance. C'est quelque chose de très encourageant que vous ayez même déjà eu des rencontres avec les chefs des aires pour discuter du fetch et voir dans quelle mesure les performances peuvent être améliorées sur toute la cascade pédiatrique. Alors, la première chose à laquelle je voudrais penser, c'est la planification et la seconde, c'est la coordination. Et je pense que à votre niveau, en tant que chef de district, c'est des choses que vous savez très bien faire parce que vous êtes un organe de planification, vous êtes un organe de mise en œuvre et vous êtes un organe de coordination. Ça veut dire que vous connaissez votre district mieux que quiconque. Vous connaissez les aires de santé, vous connaissez chacun de vos chefs de district et vous connaissez vos formations sanitaires, qu'elles soient formations sanitaires leader, privé ou public. C'est un avantage considérable. Donc, moi, ce que je vais suggérer, au lieu de poser des questions, ce serait de vous proposer d'avoir un nombre, un line listing effectif et efficient de toutes les formations sanitaires de votre district, des enfants biologiques, des enfants exposés. Et tous les centres qui proposent la PTME ou qui reçoivent les femmes enceintes au quotidien doivent être votre objectif. Donc, progressivement, vous devez accompagner ces sites à vous donner un nombre exact d'enfants exposés qui seraient attendus dans leur formation sanitaire en fonction du nombre de femmes enceintes VIH positives qu'ils reçoivent, soit par jour, soit par mois. Vous pouvez le faire sur une période. Je crois qu'avec le Pediatric Search, c'est quelque chose qui avait été commencé, mais qui n'avait pas été vraiment effectif dans les formations sanitaires, qui n'étaient pas appuyées par les partenaires. Mais je pense qu'avec le Fetch, c'est quelque chose on peut rattraper. Ça veut dire que dans ces formations sanitaires, vous devez avoir ce line listing et encore plus dans les formations sanitaires qui offrent le traitement ARV. Donc, si vous avez un focus sur ces formations sanitaires, les APS qui sont en charge des cohortes dans ces différentes formations sanitaires qui offrent le service de traitement ARV doivent être en mesure de vous donner pratiquement le line listing des enfants biologiques des parents qui sont sous traitement. Là, vous avez une idée claire de ce que vous attendez et à partir de là, maintenant, vous pouvez planifier les descentes sur le terrain et rechercher ces enfants. Donc, c'est un avantage c'est un grand avantage pour vous d'être chef de district et d'avoir votre équipe sur place que vous pouvez coordonner et que vous pouvez descendre même pour les supervisions pour assister. Pour la stratégie proprement dite, elle dépend, comme Bertrand a dit, elle dépend de votre environnement. Dans certaines communautés, c'est le porte-à-porte qui marche. Dans d'autres communautés qui sont un peu plus difficiles, il faut faire une descente ciblée, etc., etc. Donc, ça dépend vraiment de la stratégie qui marche la plus et intégrer cette stratégie à votre, I hope that I'm audible.
Yes, Doc, we can hear you.
OK, OK. Et vous pouvez intégrer ces différentes stratégies de dépistage lors des stratégies avancées, quel que soit le domaine. Ça peut être dans la vaccination, ça peut être dans la recherche des cas de rougeole, ça peut être dans tout. Donc, si vous intégrez, je crois que vous aurez un avantage considérable pour améliorer votre performance au niveau du district. Une autre chose, c'est la planification. Les descentes que vous allez planifier au niveau des aires de santé ou dans les formations sanitaires, parce que normalement, le fait, c'est une activité doit être routinière. Donc, on doit la considérer comme un dépistage de tous les jours, une recherche de cas tous les jours, que ce soit dans la communauté ou que ce soit dans la formation sanitaire. Donc, lorsque vous faites la planification, on la fait au niveau de la formation sanitaire. On peut la faire également au niveau du district avec l'équipe de district qui est en charge, qui peut faire des descentes dans des stratégies avancées. Et vous prenez cette opportunité-là pour faire les dépistages des enfants. Bon, maintenant, on a parfois eu des problèmes avec le lien au traitement pour les enfants qui ont été dépistés positifs. Bon, je ne sais pas si c'est votre cas, mais il faut pouvoir identifier des formations sanitaires qui offrent le traitement. Et si dans ces formations sanitaires, l'équipe qui est en place est également qualifiée pour la prise en charge pédiatrique, parce que la prise en charge pédiatrique est bien différente de la prise en charge adulte. Donc, il faudrait que le personnel de santé qui est dans les formations sanitaires soit formé, capacité pour pouvoir recevoir ces enfants et pouvoir les mettre sous traitement. Par exemple, le pays est en train de faire la transition du DTG 10 mg au DTG 5 mg qui sera en formulation combinée. Donc ça, c'est quelque chose qu'il faut savoir. À partir du mois d'avril, tout nouveau enfant qui va être dépisté VIH positif devra être mis sous la nouvelle molécule. Ça veut dire qu'en stratégie, en priorité, vous devez pouvoir, avec la région, entrer en possession de votre stock de DTG 5 mg, par exemple, auquel cas, lorsque vous aurez un enfant infecté, vous pourrez le mettre sous traitement et la forme la plus optimisée possible. Bon, en ce qui concerne les défis, je voulais dire aussi que la liste combinée de tous les enfants biologiques, les frères et sœurs des enfants infectés, que vous allez avoir des différentes formations sanitaires, vont vous donner une liste que vous aurez au niveau du district et ça va vous aider maintenant à monitorer les activités, à monitorer les descenses et à monitorer les progrès que chaque aire de santé, que chaque formation sanitaire fait à son niveau et vous aurez de façon globale la performance de votre district. Maintenant, vous avez parlé de quelques défis et j'aimerais vraiment savoir. Le premier défi, c'est l'accord parental pour le dépistage. Euh, ce serait, bon, je dirais que c'est quelque chose qu'il faut revoir parce que en fonction de comment la mobilisation a été faite et en fonction de la communauté, c'est quelque chose qui peut être géré. En ce qui concerne les intrants, je ne sais pas, il faut voir avec la région en anticipation comment faire pour ne pas entrer en rupture de stock. Donc voilà un peu brosser quelques éléments que je peux donner pour vous aider à améliorer vos performances dans le district. Merci beaucoup. Au revoir, Vanessa.
Okay, thank you very much, Dr. Yufu. And thanks also. I think one key thing I picked is that we have to do effective line listing so that we should be able to identify the cases. Thank you very much. And I'm sure Mintum has noted all the recommendations and they are going to implement it. and we are going to see the results reflect. I think the good thing is that all the health areas within their health districts are implicated. So I'm sure as they have gotten some of this feedback, they are going to implement, and we are going to see better results when we have our next review. Again, if you are just joining us today, we are discussing the pediatric fetch, which is find every child. And we've just had a presentation from Mintum, the Mintum Health District. And in a very short while, we'll be getting a presentation from the Mwa Health District. Again, I'm seated with the Mwa Health District team, and also joined by somebody from the regional technical group in the person of Mr. Paul. We are all seated together and taking the call together. So please, again, there's interpretation available. Our second presenter is going to be doing her presentation in English. So if you need translation, you can go to the globe at the bottom of your screen, and you'll find that, and you pick the language that you want. Right away, I'm going to hand the floor to Madame Sama Dorothy, who is going to take us through the presentation for the Mwa Health District. Thank you. You have the floor.
Thank you, everyone. Good afternoon. Thank you, Dr. Vanessa, for giving me the floor to present the first activity for Mwa Health District. I am Sama Dorothy here, the focal person for PMTCT in Mwa Health District. Slide. Mwa Health District is one of the 21 health districts in the Northwest region, composed of 7 health areas with 13 health facilities, of which 7 are public, 4 confessionals, and 2 lay private, serving a population of 62,542 persons. From January to date, we have tested 311 children and adolescents, achieving 62% of our testing targets, identifying 2 positive, all linked to treatment. We have partners supporting the district in its activities, including PATA, the CBC Health Service in pediatric HIV through PMTC in the context of the Cameroon Pediatric Breakthrough Partnership, and VESUS in the EPI activities. The principal challenge we have with the pediatric HIV has been that of suboptimal case finding. This is largely due to the refusal to test, especially by school-going adolescents, parents refusing to bring their children for testing, and Mwa has very far-off communities from the available health facilities. And we know Mwa is a difficult terrain, one of the difficult terrain in Mwa. It is therefore imperative to have more outreach activities. However, the means to go to the community is lacking. And we also have the problem of shortage of human resources. Most of our health facilities here in Mwa, they have just one staff, and this staff cannot carry out the health facility activities and the community activities. So where we have a gap, I think here there is a low ANC uptake. Therefore, we miss testing women early. Low retesting during vaccination clinics. While line listing has been done for index testing, the challenge is with the testing the contact elicited. We also have post-screening for eligibility at entry points in the health facility. Slides. So far for the first activities applied in the district, first activities started in the Mwa Health District on the 12th of February 2026. In Mwa Health District, there is 1 facility carrying out this activity. We have just 1 phone available for this activity, and the health facility carrying out this activity, we have the Senkisito Catholic Integrated Health Center that do this activity in the district. Slides. So far, the activity being carried on the field, they do line listing and testing at the community and the health facility. So far, they have line listed 81 mothers and tested 101 children, of which 2 were positive and all linked to treatment. Slide. For our yield, the approaches that we use to have these results, we have been doing index testing. Having index testing remain the mainstay for case finding in the children. School testing has yielded good numbers, especially amongst adolescents. Next, we have strategic outreach activity also permits testing of contacts. Slide. The role of the district. The district follow up on requisition and supply of commodities to ensure implementation of activities. We also use the district coordination meetings as a forum to review the data, identifying gaps and propose solutions while promoting exchange between health facilities within the district and identify areas to foster collaboration for better results. This is equally an avenue for shared learning. We also carry out routine mentorship activities to strengthen performance. Slides. Our results so far, we have observed a marked increase in our testing coverage, especially in the sites implementing the activity, and would like to scale up this to the other sites. I think I talk of 5 sites that we have to scale up these activities at the sites. The next, we have the main challenge we have is the network. Network is a problem in Nwa. To upload the forms and electricity in the whole district, we don't have any electricity in the district. We manage with our solar system, which at times don't work. We have the problem of commodity stock out, which has equally been a challenge to us because to get to the region for commodity, the region is really far off from the district. Then the last, we have the threat that remains is the insecurity in certain parts of the district that limits full implementation of the activities. Slide. Our activities for the next 30 days, we want to add 5 more sites to carry out fresh activity that is at least 1 per hair area. We want to ensure 80% of women on treatment have their children and sexual contact tested for HIV. We want to advocate to key stakeholders in Nwa to reduce stigma and improve sensitization in the community through a clinic community dialogue. Slide. Our lesson learned. When we sensitize, we have more people who show up for testing and also carry out outreach activities will help us to move forward in all what we have planned. So our one problem that we have one challenge that we face is the challenge of people refusing to be tested due to cultural beliefs. So we want the panel to help us on how we can go about this, our challenge. Thank you for listening.
Thank you very much, Madam Dorothy, for taking us through your presentation and letting us know what the Nwa district has been able to do. I think if all of us were following, one site has done a lot. And so I think their plan of adding 5 more sites only means that we can have a lot more happening for us to achieve the kind of results that we want to. Again, I'm going to give the floor to Dr. Aso, who is going to first answer the question they're asking around how they can do with these people and their cultural beliefs. And please, again, we like to know who you are. Please go to the chat box and introduce yourself and leave your comments. If you have a question or a reaction, please raise your hand and I'll give you the floor to speak. Dr. Hassan, you have the floor. Thank you.
Thank you very much, Dr. Vanessa, again. Thank you very much, Madam Dorothy, for the wonderful presentation. I want to commend you and your team for taking the bold step to locate these children in the community, especially in the context of insecurity. I'm well aware of the situation that people have. Now, straight away to your question. I think in any community, people are more receptive to those that are culturally sensitive. So if at all you're coming to a community and you bring your own idea about your culture, especially if it's against their beliefs, they will tend to have a lot of resistance in what you're bringing in. So if we have a mindset of accepting or beginning by acknowledging these core community beliefs that they have, rather than confronting them, that is a good step to begin our collaboration with them. In simple terms, let us avoid framing HIV testing as a medical imposition on these people. Instead, let us present it as part of the overall child health that a child is going to go through when they come to the hospital, which is expected of the family to make sure that the child. I think that alone is going to help those that are there in the community to understand you to some extent. It's also important that when we go into the community, let us use those that are versed with the local language. Okay, so if you are in a Muslim community, it's good that someone who is culturally linked to that community should be the one leading. Because when they see that person, there is a greater chance that they're going to accept the information that is coming in that another person getting it. The second thing is that we have to engage trusted community leaders. Now, generally, when we talk about community leaders, we think of the chiefs, the religious, maybe the imam, and all of these women, head of leaders of women groups, youth groups. But there are also key people in the community. There are also key people in the community who are not part of this. So what we have to do is to identify those in the community who people listen and try to somehow sell this idea to them. Once they buy it, it will be easy for them to send this information to those that are in their network, and it's also easy for the community to engage. I mentioned in the previous presentation about normalizing HIV testing in our routine activities, which I think it's a good idea that each and every facility, especially those that you scale up to involve making HIV testing to be part and parcel of their immunization, their nutrition, and malaria campaigns. Storytelling is a very big part. So if at all you have someone who has gone through the HIV scenario and has a success story to tell, when you engage these people through community facility dialogue, as you mentioned, it's a milieu for this person to talk about their experience and also help the community to understand and engage really well. So these are some of the strategies that I think you can use, but I always stress on the fact that it always depends on the community which you are. And you as the head of the district understands perfectly well how the community behaves and what are the things that can make them engage more to all the campaigns that you have been taking through. Thank you.
Okay, thank you very much, Dr. Asson, for that. Right away, I'm going to hand over the floor to Dr. Alette. Like I introduced earlier, Dr. Alette is our expert, and she is going to provide some elements of response to this question, but she's also going to queue up to continue with her presentation on FETCH. And I'm sure that in her presentation on FETCH, she's again going to highlight some of the strategies that we have been mentioning. So Dr. Alette, if you can hear me, you have the floor. Thank you.
Thank you, Vanessa, for giving me the floor once more. Thank you, Mwa District. I think I want to say that I'm very happy to see that activities are picking up in Mwa District. We have been having challenges to really put Mwa District in the board. So I'm really happy to see that you have started and you even have a plan to scale up the activity in 5 sites. So I think that with the little support that we can give, and with Vanessa there, I think that things will be better very soon. Maybe to add to what Dr. Bertrand already said about how to go about the difficulties to test people because of beliefs. I think that sometimes people are not just informed. They don't just have the right information and they don't really know where to get the information. So I think at our level, it's our role to make sure that everywhere that we meet people, be it in the community or in the facility, they can have the right information. I'm thinking about the messages in local languages that could be passed over and over. Maybe I think the district has the megaphone. When you go for advanced strategies, you can use it and pass the information in local languages. We can see the church leaders and use the opportunity during the churches to pass the messages. At the facility, when we receive them, we should also ensure that we have a system where they can get the information over and over. I think that if we do that, it can increase the awareness on the HIV and what we are expecting from the community and what we are able to give them as to offer as a support. So I think that this is only what I can add to what Monsieur Bertrand has already said. So thank you very much. And I want to wish you courage.
Thank you. I'm happy. I'm grateful.
Thank you. So I'll just continue with these few slides that I prepared for us. I think it's just a story where we started and where we are. And this strategy of looking for children in the community and in the facility is something that we were doing, but in a different way. In 2024, the country adopted the pediatric search, which is just meaning looking a child wherever the child could be. So we follow this outline slide. Yes, the pediatric search effectively started in October 2024, but the preparation started January 2024 with all the meetings, planning, and all of that at the central level, and at the community level, in the field, in the health facility. We really started the implementation in October 2024 after the stakeholders have been trained on the strategy slide. So because HIV AIDS is a big public health challenge, because of the fact that despite all the strategy that we have been implementing to mitigate it, we couldn't reach the expected targets, because we have a gap across the pediatric cascades from the case identification through linkage, initiation, and even coordination and management of stock commodities. And because of the fact that we need to achieve the 95 goals by 2030, the Cameroon decided to launch the pediatric search slide. So the objective of the pediatric search in Cameroon was to accelerate progress towards controlling the epidemic among children and adolescents in the 10 regions of our country across the entire cascade of HIV prevention, care, and treatment. And we had the figures that we wanted to achieve. And the pediatric search was divided in phases. So we had the first phases and the second phases. And according to the treatment current already that we already have, we set targets at the national level, which each region had to achieve. So after calculation and brainstorming, the pediatric search had to be implemented in all the regions. 203 health districts were selected, more than 1,000 of health facilities, and more than 4,300 satellite sites. Slide. So this was the situation that we had at the beginning of search. It's because of this that we realized that we need to do another way. We need to do differently to be able to meet the target. When we take the first 95, for example, let's take the Northwest region. The Northwest region, for the less than 10 years, we are at 43% case identification targets achievement. we are doing well on the second 95, but we are still lagging on the third 95. When we take the 10 to 14 years, we see that we are doing a little better. We are in green in the Northwest region, but concerning the third 95, we are still lagging. When we take the 15 to 19 years, we see that we have 66% achievement for case identification and 80% for viral suppression. So because of that, the Cameroon decided to adopt the pediatric search and to be implemented once in all the country, in all the 10 regions. Slide. So we asked the question, how to improve ART coverage among HIV positive children? We need to find the positive children and place them on treatment. So the pediatric search was a multi-strategy approach that aimed to intensify the search of HIV positive case and link them to treatment in order to improve ART coverage. So it was a strategy to implement in the community and in the facility. So the Cameroon decided to implement the pediatric search as a key to improve the performance, the indicators across the cascade. Slide. So with regard to strategies, we have facility-based strategies and we have community-based strategies. So at the facility, we have to cover all the entry points. We have to assess nutritional status because we know that HIV can lead to malnutrition. We need to create awareness on HIV, tuberculosis, and vaccination. So all the entry points, all children coming to the facility with unknown status have to be tested, and we have to refer to prevention services according to the results of the test. At community level, we have to create awareness. We have to identify households, as Dr. Abada said. We have to identify suspect cases in the community and now organize a targeted testing. We also had to test exposed infants with the line listing done. When we have the line listing at the health facility, the team now organize the testing in the community to look for the children that we are expecting to see. And we also have at the same time the opportunity to collect samples for viral loads, PCR, DBS, and all of that. Slide. So for the screening, we test individual. They are connected either to prevention services or care and treatment services, depending on the result of their HIV test. Those who are positive, we need to initiate them on treatment. And the most important thing is to show what we are doing. And for that, we have documentation in the different tools. And we know that to validate a testing in Cameroon, the information needs to be in the Cure-A register. And the tool that we had for this pediatric search that has been designed for the pediatric search was the scan form. And this is actually the same scan form that we are using for fetch. And we also know that our CSU we should use the opportunity to enroll those positive children in CSU so that they can benefit to the services, the free services that the country is offering. Slide. So at the end of Q3 FY25, this is where Zone 1 were. You see that for testing, we couldn't achieve our testing targets. In the West, we were at 64% testing targets, in the Southwest, 82%, and in the Northwest, 51%, giving us for the zone 63% testing target achievement. Slide. For positives, this is before we started the fetch. This is the results for the pediatric search in Zone 1. For positives, you see that for the zone, we were at 28% achievement with 289 children identified within the period of the pediatric search. You see that be it in the testing and case identification, we have accumulated a gap that we have to carry out to the next next approach, which is fetch. Slide. So from August last year to date, we are implementing fetch. Find every child. So the background is that the pediatric search at least permitted to the country to identify over 1,000 children in 6 months. It means that it is a strategy that can heal, that can produce results. We also realize that 35% of the new infections are below 10 years. And one of the other challenges we have at that time was the EID in country, with many HIV-exposed infants with unknown status that we had to track. Slide. So the objective of the fetch was to bridge the gap in pediatric case identification and use the model of the district approach to engage the district and the model for some program strategy, as Dr. Abada said, use this approach district to reach the people in the community, to reach the house, map out the district to understand the epidemiology. I think at the district level is something very easy to do. The district has the data and the performance of each health facility, each health area within the district. And from the data that we have from these facilities and health area, we can see which district has a yield or a good yield where we can go and find a children. And we can also look at another sense, another way, a district maybe or a health area that produce results during the pediatric search. We can prioritize those kind of districts and plan the testing in those communities. Slide. So when we started with fetch in July, August last year, the Northwest had identified 6 children positive. So you see that it's not really a good performance. When we see our position amongst the other region, we are not the last, but we are not the best. Slide. So here are the target that we have for the fetch. This is only for a period, and we need to understand that fetch has come to stay. It should be considered as a routine activity. So even after the February periods, we should continue to have targets that we need to achieve. So when we look at this performance, let's look for the Northwest. Our testing target was above 11,000 and the positive 72. We succeeded to test only 1,800 and we got 13 positive with a yield of 1%. And if we want to compare our performance to the target, we are at 17% testing achievement and 18% case identification achievement. And if you consider the Mwa district presentation with what they have been able to achieve, with all the challenges that they are facing, and also the time that they started with pediatric, with fetch, you can understand that with this kind of performance, and if all the districts perform the same, we will never meet our target. So I think that is a time to set to really put everything together to implement the activities and to get the result. When we see this performance, we understand that we have not really put strategies in place. We did not implement with fidelity. So we cannot really say that we couldn't meet this target because we did not really test. We cannot say that we don't have positive children because we did not really look for them. Slide. So as guidance, we just want to give few guidance to district, and understanding that districts should adopt what can work to their community. So we want to propose to map the health areas, the facility within the district, to identify hard health area to reach for testing, to do the line listing in all the health facilities. You line list the HIV exposed infants, you line list the biological children of adults on ARVs, you line list the siblings, and from there you can go to the community and look for them to test. And the RPS are there to support the team, and the district is there to coordinate, to supervise, and to regulate, and also ensure that at facility level in our district, within the district, we have covered all the entry point. We have screening tool. If we screen and the child is eligible for testing, you test, and all of that. Slide. Yes, it's good to have a focal point at the facility, and the focal point has a responsibility to do the plan of visits in collaboration with the district, because a community descent cannot hold in the community without the district being aware. So the planification should be done both or together with the district team, because before the testing, if it's the door-to-door testing which is working in your area, you need to first of all do the sensitization and make the people be aware that a testing team will be around. And we also want the data review done, be it at the site level or at the district level, to be able to analyze the performance, ensure the data, and also do triangulation of the data. We also want the scan forms to be available. We know that sometimes we have stock out of scan form, but the team need to work ahead of time and notify when they are in need of scan forms. And it's very important that each district should know the target that has been assigned to a slide. So we really expect to identify and place on treatment all the positives that we will have. As I said before, the facility where the staff, the healthcare provider, are capacitated to take care of HIV positive children should be prioritized and link children there for care. We should ensure that as we come from the community with our testing information, we fill the scan form and we upload. We know that sometimes we can have internet challenge that can delay the uploading of forms, but if the forms are already uploaded in the phone, anytime that the network is available, it will just go in the system, in the dashboard. Another thing very important is the correction of the decree, because sometimes when you fill the scan forms, you can make errors, you can make mistakes, and when you make the mistakes and you scan and upload the scan form, that form will never be shown in the system, and your effort will never be reflected in the dashboard. The weekly data review meeting is very important, both at the facility and at the community level. And please, documentation in standard tool is a national strategy. It's not a partner strategy. So our QA register, our PCR booklet, our DHES2 should be updated, should have the same information. So don't go and test in the community. You keep it in your office. Document standard two are not filled or are not updated, and you think that this will be validated. No, all these tools that need to have the same information. and we need to discuss challenges and implement a recommendation that we take as a team. And the most important thing is to note that fetch is a routine activity to find HIV positive children wherever they could be. So this is what I wanted to share with all of us so that we have a little refresher on what is fetch and what we are expecting from you as a team. Thank you very much, Vanessa. Over.
Thank you very much, Dr. Yefu. I think everybody is now up to speed. We now know what pediatric search is and what the fetch that we are currently doing is. Thank you very much. I'm wondering if there are questions. If you have a question, please raise your hand. I'm going to call you. While people are mobilizing for that, I saw that the South region was doing well in terms of fetch, or at least in terms of testing for fetch. And if we listen to Dr. Abada when she presented, I think she highlighted some of the things that they did before starting, which is again what Dr. Abada has shared in her presentation. So I don't know, Dr. Abada, do you think there's something extra you people are doing in the South that is permitting you to have higher achievements in terms of testing that you want to share with the others? I don't know if you have. Please, for the others, if you have questions, please do raise your hand. I'm going to call you. I know there have been a lot of challenges, especially with the scan forms. So please, if you have questions, don't hesitate to ask. Dr. Abada, you have the floor. Thank you. Hello, Dr. Abada. I don't know if she can still hear me. Oh, Monsieur Bissot. Bissot. C'est Bissot. He's not there again. Anybody still connected from the South, please? Okay, I think we lost the team from the South, but it would have been very interesting to hear from them if there was something extra they were doing to let them identify. Okay, okay,
Allô?
Dr. Abada. Yes, you have the floor. Allô, docteur, vous
Pour ce qui
m'entendez?
est de l'identification des patients, c'est vrai que nous avons eu à faire un certain nombre de travail sur les femmes enceintes. Ce qui fait que nos recouvertures en, nos recouvertures en CPN est élevée, ce qui fait que nous captons quand même la majorité des informations qui sont liées aux enfants. Pour ce qui est du dépistage, nous-mêmes pertinemment, on sait on doit améliorer plus. C'est vrai que en fonction de la population, il faut voir ces indicateurs-là. Mais on sait que en termes de dépistage des enfants et des adolescents, on doit améliorer. Tout part déjà de la CPN et des femmes allaitantes. Si on vise mieux les CEPON, ça veut dire les consultations postnatales avec les opportunités de vaccination, des stratégies avancées, je crois que nous améliorerons mieux ce dépistage-là. Il faut aussi dire que le partenaire qui a été aussi pour beaucoup, parce qu'à un moment, on dépistait vraiment dans les localités de dépistage volontaire, ce qui a permis qu'on améliore aussi cet aspect dépistage dans le district de Minto. Maintenant, d'autres éléments, je crois que c'est en gros ça. Merci.
Merci, Dr. Abada. Thank you very much.
Well, a huge thank you for everyone who joined PATA REAL today, this PATA REAL in Cameroon. I think we've lost Dr. Vanessa right as we were wrapping up for the day. We can give her another minute to join or and then just wrap up, but just to appreciate everyone who's been on the call. Thank you for staying with us, and thank you to all the great presenters.
Hello, Angelita. This is Fanny speaking. Hello, can you hear me?
Yes, we can hear you, Fanny. Please go ahead.
Okay, thank you so much. So while we wait for Dr. Vanessa to join the call, I know she's where there are huge issues with the network. However, I think just to continue to engage the teams, this is a breakthrough activity. And from the presentations and the conversations, we heard some of the challenges they raised. A few weeks ago, we had engaged these districts to do micro plans for their districts. I want to just find out from them, based on Dr. Yefu's presentation, are there some things they've learned that they want to integrate into their micro plans, make adjustments to them as we move forward into the third phase? So it'll be nice to get their perspective. Hello, Dr. Abada.
So, we are here with Nwa. Sorry, I'm connected
Okay.
now to the phone. So, Nwa, how did she want to respond?
Okay, thank
Okay.
you. Thank you, Madam Fanny, for that presentation. I think from what Dr. Ifu has presented, I think most of our plans, we are plan to like implement the community sensitization and others that she has presented. So we don't have anything new in our action plan.
Thank you so much, Madam Dorothy. What about the resources? I know she indicated some of the things that are needed. You highlighted that you have just one phone to use for for the exercise. Are there resources that you now have a clearer understanding as to what you would need to roll out this for the remaining 5 facilities?
I think, Madam, I did not mention that because I know that when they will scale up, they will also add the number of phones to the new site.
Okay, maybe I can say something. I think one of the things that is going on now is that they are trying to see the possibility of having a phone in the health facility to be registered to scan. So not just the phone that we bought, but somebody's personal phone. And that way we'll be crediting the phone so that they can scan the phone. Already when we were in ACO last week for the training, we went through the process because one of the gaps we identified was that a lot of healthcare providers did not even know how to fill the scan forms. And some of them were filling the scan forms with errors. But because we came down and we have a team from the CBCHS who have been doing this activity and have a clear understanding of what has to be done, they have been able to really take time and go through step by step on how the forms have to be filled. And we have registered the additional sites in Akko Health District so that they start the activity. So we'll just be following up now with the person in charge of the dashboard to see whether the forms have reflected or not. So in the meantime, that is the plan to see whether using personal phones we can be able to scan those forms. But like I said, one of the big gaps is that they don't even know how to scan to fill the forms properly. So that's what we are really engaged with. And now we are on the field. We are now in Nwa, and the same activity we did in Akko will be done in Nwa, where we will go through that process of filling the forms together with them, and then having particular phones that we'll use to scan, and then we'll follow up to see whether it reflects in the system. Thank you.
Thank you so much, Dr. Vanessa. I know Lucian is on the call representing ECPAF, as well as Patrice. And we're having colleagues from the center and the south region. It will also be good to know if they have challenges completing these forms, so that as we plan activities to the field, mentorship activities, we can integrate these in the plans. Thank you, and over.
Okay, thank you very much. And thank you for stepping in. I mean, it's PATA real, so it gets real. So again, thank you very much. The other thing I wanted to say was with regards to traditional birth attendants. I'm aware that in the south as well as in the northwest, in fact, in all the regions, we do still have these traditional birth attendants, especially in these districts that are not supported by PEPFAR and the districts where the breakthrough partnership works. We still have a lot of women who go to deliver with the traditional birth attendants. And I just want to call on all of us to find or create avenues where we can have a session to discuss with these people, because they're very essential if we want to find every child. They're a key stakeholder. So while we are looking at pastors, traditional doctors, we also need to make sure that we are looking at traditional birth attendants. There are communities where the traditional birth attendants see double the number of children that are seen in the health facility. So we need to find a way to work with them, to orientate them, let them understand what they're doing, and see how we can go ahead and test the children that were born maybe in these places, or children that go there for consultation. And then we'll be able to also capture that information. That's what I wanted to add so far to the discussions that we've been having. So I think the challenge with the filling of forms, we are looking out to see how we can support that. I wanted to find out from Leslie, how many facilities in Baham are carrying out the fetch activities? And is any of our sites involved so far? Hello, Leslie, can you?
Yeah, Dr. Vanessa, thank you for giving me the floor of that to each and everyone. Okay, so in Bangkok we have four hot facilities. We have Ashley, we have Sufikan, we have Hospital Baptiste, and we have Escadron of Pute. For us in Maham, there were Ashley, Ashley, Bapa, Bakiala, Bangu Kaufu, and Bangu Ville. Actually, we have one site, which is Ashley, that's carrying out the activity in Maham, whereas in Major, we have two sites.
Okay. Thanks. So from what you have said in Banjok, I think two of the three sites are in the activities. That's Ashday and
all the three sites,
and then in Ban.
We have Ashley, Sufikam, and Hotel Baptiste. Whereas in Maham, it's just Ashley.
Okay. So I think like we are, and that one of the challenge is really completing the forms. I don't know whether all these sites have the phones to scan.
I think there was a shortage. There was a shortage in scan forms in Banjok, but the region said they were going to bring it. But I don't know if they bought it already. But in Maham there was no shortage. Then in Banjok too, there was the two forms got missing. Two forms got missing because the health facilities were robbed. All facilities were up. So two phones got mentioned. So there are only two operational phones, that of Ashley and that of Escadron.
Okay, so there are two in Banjok.
Mm-hmm.
And then in Baham.
No, all the sites in Baham, they have the phones. They have their phones and they have sufficient scan form. But now I don't know if I can just talk about the difficulty, if I may.
Yes.
Yeah, as they rightly said, this activity is supposed to be a routine activity. But the problem is that when the project started, that's not the information that was given to the site. And so this site worked, and later the partners changed. The partners changed and they were not paid before the partners were left. They were not paid. So whenever you go back to them and you're like, You have to fill the scan form. I think the last time we even had the validation, before the validation meeting, we had to use, I had to go down to the field. I had to go down to the field personally for the scan form to be filled and scanned. And now the fact that we're using one phone to scan maybe for two sites, I think it's also, that's why because told me that they were not seeing the data. And now to the district don't also have the facility to see the dashboard. Because at first with search, the district had the facility to see the dashboard. And we also had the ease to enter for data quality control. When you enter data quality control, you can correct the error, or you can tell this team that your scan form number 5 has an error at this indicator. What I did is that I organized a session where I thought I rebriefed the teams on how to do the scanning because I was trained on scanning, on how to use the scan form. So the new members that are there, I trained them on how to fill the scan form and how to do the scanning. Now, another problem is that these phones, they told us that they were supposed to be receiving monthly credits, but they were not. No, why not? So at times, if I know, it's not that I call for a meeting at the district level where they come and sit, we do the scanning, we do the filling and we do the scanning. Because what I did is that during my first data quality assessment, I noticed that there were a lot of errors. So what I told them to photocopy the scan forms. Now, when the team goes out for outreach, they use the photocopy. Then they come out when we call for the meeting at the district level we fill the original scan form and we do the scanning. So now we have no means of follow up to know whether the scannings are being, if the platform is being uploaded or not. So that was our difficulty. And the fact that these things went down and they had not been paid with the previous partner, it was really difficult when ECPAS came and said they should start it back. I think the West Region, when ICAP came to, after CDC had left, it was really difficult to start. And still up to now, I think the teams are still waiting. But in the West Region, so we hope from now to then the situation is going to get regularized by the partners. Thank you.
Okay, thank you very much, Leslie, for that. I think one thing I know is that you don't use one phone for two health facilities. You use a phone uniquely for one health facility. Dr. Yefu, I don't know if you heard, I think some of the challenges, he said they are not able to see the dashboard. And so it's difficult. He said during the search, they could see the dashboard and so could even make some corrections, but now they are not able to see the dashboard. And so it becomes difficult. I don't know if there's a mechanism by which they can know that they have errors because they may be sitting comfortably that they have scanned, meanwhile the forms have not gone through or the forms have been rejected. And I think we even saw a situation like that in ACO last week where the chief of center was comfortable that she had scanned 10 forms in her phone, showing uploaded, but it was not reflecting in the system. And it was only after working with her that we realized that they had not scanned the registration page before they started the scanning process. So I don't know what we can do to mitigate something like that. I don't know if you have maybe some other responses to the other things you said. Thank you.
Yes, Vanessa, thank you very much. I think that the first thing is to ensure that the registration form has been scanned before you start uploading the scan form. That is the first thing. The second thing is to ensure that if you have registered already the cover page, you need to find out if the DQA did not pop up on that particular form, because when you do the scanning, if there is a mistakes, if there is errors, the DQA will pop up and then you will be able to see the DQA and go to the form and correct where there is a mistake and you rescan. If you don't do that, you will fill this form, you will scan, and you will never have a reflection on your efforts in the system. So this is two major things that we need to do, because when you scan the forms go to a kind of waiting room, And if there is any mistake on that form will never be validated to appear in the dashboard. So this is how things are functioning. So if you do that and the problem is still persisting, you can reach out to your regional focal points, and there is a WhatsApp group where you can send the complaint, explain what you have at the level of your site, the field, and you can get a response on your problem. Thank you.
All right, thank you very much, Dr. Alet. And I think let's say in the weeks ahead, when we come around for mentorship, we are really going to look at search and see how we can support in the activity and what more we can do. I think Madame Fanny mentioned about our action plans. You see that in the presentation Dr. Yefu did. Our activities are supposed to help us accomplish our targets for fetch. So when we come and we are able to review the action plans, we'll be able to put everything in perspective, and we'll be able to have a clear way forward. And I'm happy that we have now learned that fetch is a routine activity. So please, let's get everybody to understand that. And like we said, we'll see how to support these activities to see that we are achieving the expected results from the activity. Again, I want to thank everybody who took part, the presenters, Dr. Abada, Madame Dorothy. Thank you very much for taking the time to put together the presentation and telling us about your district. I also want to thank immensely Dr. Yefu, who was there to provide her input and to take us through the presentation, and Dr. Asong as well for valuable input. I want to thank Angelita, who was at the back end with our tech and all the translators for the work that they did. I mean, it was a marvelous session. I know that we've gone a little bit above the time that was slated, but I want to thank everybody, and I know that the discussions we've had are going to help us to go further. I'm going to hand the floor now. We have the next PATA REAL session in June. We'll let you know the date and the topic. I will hand the floor over now to Madame Fanny, who is the coordinator of the Breakthrough Partnership in Cameroon, who is going to close the session for us. Thank you, and over, Madame Fanny.
Thank you so much, Dr. Vanessa. Thank you, everyone, for all our participation. One thing which remains is the fact that we are dedicated to ensuring that every child who is living with HIV is identified. And we cannot do this by ourselves. We want to really appreciate every one of us for all our commitments and know that we are there to support you. The way to go is by engaging the district, and that is how we have to do it going forward. So be rest assured that we are there to support you through this process, and we are going to find every child in the community. Thank you all, and let's have a wonderful day. Bye-bye.
Thank you, Fanny. Bye-bye. Thank you, Vanessa.